Renal colic. So renal colic is, at least for men, the worst pain in the world, I'm told. Terrible, terrible pain. And you see the patient with renal colic, you all know who those people are. They come in holding their flank and they're writhing around, they usually are diaphoretic, and they're vomiting. They need to have an IV started right away, get their vomiting taken care of with Zofran, and I give them pain protocol plus Toradol. And why do we do both? This is really important. The Toradol is extremely effective for any kind of stone pain, whether it's gallstones or kidney stones. Extremely effective, but the onset of action is 20 to 30 minutes. Those people are hurting right there. The onset of action of morphine is a matter of minutes. So you start pain protocol to get immediate relief, you use the Toradol to get prolonged relief, and then you probably won't have to use any more morphine. So that's why you use both. You don't give them Toradol if they're allergic to aspirin or NSAIDs. All right? And you grab a UA. Remember, even if they look like they have renal colic, but the urine doesn't have blood on it, that does not rule out a kidney stone. Fully 30% of people who have renal colic who have a kidney stone don't have blood in the urine. Why? Because the stone is so big, urine's not coming through that ureter. So there's no blood, it's getting down the bladder. It's completely obstructed. So the worst stones may not have blood in the urine. That doesn't rule it out. People are not trying to fake you out. Treat their pain. A lot of times these people come in, you'll notice that the docs are not going to do an imaging study. Why? They've had multiple renal stones before. They've had lots of CAT scans before. They don't need any more CAT scans. They need their pain treated. All right? And that's what we need to do. I'm told the only pain worse than this is childbearing. I believe it. But we need to be on top of this in terms of pain protocol. Okay, so now we're going to get into another one that's a little bit more complicated, respiratory distress in adults. And we all see these patients, the bad asthmatic, the COPD, or the CHF, or pulmonary edema come in. So, these people are sick. The doc needs to be notified as soon as possible if they're in respiratory distress. You need to get them on O2, put them on a monitor, get a line started. Be very careful. On our policy it says if they are vomiting, give them a fluid bolus. But only do that if they don't look like they're in CHF. And you know what CHF patients look like. CHF patients usually are diaphoretic, and their neck veins are elevated, and they'll have peripheral edema. Those patients do not give a fluid bolus. COPDers feel fine. Asthmatics, go right ahead. But be very careful with fluids if they may be in CHF or pulmonary edema. Go ahead and get the chest x-ray ordered in the labs. And the labs are CBC, BNP, troponin, and BNP, and get your EKG. Now, if you're worried their reason of respiratory distress, it could be pneumonia, then go ahead and give them the Tylenol if they have a fever, start them on breathing treatments, and it's albuterol and Atrovent. So, why albuterol and Atrovent? Because most of the time we just give albuterol, and albuterol is a drug of choice for asthma. But if they have asthma and or COPD, the Atrovent actually adds more bronchodilator effect. So you want to use both in those people. For nausea, go ahead and give the Zofran. And now, if you're concerned that they have respiratory distress and they have pneumonia, it's what we talked about before with the fever. Draw your blood cultures. Again, we may or may not send them, but get them drawn because we're going to give antibiotics quickly, and that's a core measure. Did we draw antibiotics before? Did we draw the blood cultures before the antibiotics in patients going to the ICU? And then did we give the appropriate antibiotics? If you think they have CHF, by all the things we talked about before, diaphoretic, neck veins, peripheral edema, history of CHF, then give them nitroglycerin sublingually, and that can be repeated as long as you're not hypotensive, as long as they're not on drugs like Cialis and the other kind of drugs. And you can put a nitro patch on, but the doc needs to know about that CHF, and we need to get them unloaded immediately. So that's very important as well. Questions on this? No. Respiratory distress in child, and now we're talking about using croup, bronchiolitis, asthma, or pneumonia. So croup, as you all know, is a viral illness. It's a classic cough. Everybody's heard croup cough once, knows that disease. You can be on the other side of the ED, you hear the cough, and you go, croup. I know what that is. So croup doesn't require bronchodilators. Albuterol will not help croup. The inflammation is higher up in the airway. It's laryngeotracheal bronchitis. And what you want to do with them, you can give them cool mist just for comfort. And we give them Decadron. It's 0.6 per kilo, and that can be given PO. It can be given IM. It can be given IV. and you want to give that to them because it reduces the inflammation and the croup will get better and improves their croup score. If they're really bad, and how do you know if a croup patient is bad? Two things: are they retracting, or do they have stridor when they breathe in? If you hear that noise, they're bad, and they probably need racemic epi as well. Again, that means you call the doc right away. They need to get over and see that patient because those kids can go bad quickly. Racemic epi usually turns them around quickly. Once you make a commitment to give a racemic epi, that usually means observation in the emergency department for 2 to 4 hours after you've given it, because sometimes there's a rebound after it wears off. So that's for croup. For bronchiolitis, remember bronchiolitis is viral. And kids can be terribly ill with that or just have a little runny nose and congestion. It depends on what that kid looks like. Oftentimes it's accompanied by fever. It's a typical fever thing. We give Tylenol for that. If they're vomiting, we can give Zofran for that, age dependent. The most important thing you can do with a bronchiolitic child is get them suctioned out, get those secretions out. You get a chest x-ray to rule out pneumonia, and you can try 1 dose of albuterol nebulized and see if they respond. My first statement is they don't need bronchodilators generally. But here's the thing, a lot of children who get bronchiolitis also have reactive airway disease. They're children of parents who have asthma. And some of them actually will respond with albuterol. So listen to the wheezing, see if it gets better with albuterol, and then we may or may not continue it. A lot of times they don't. We'll do an RSV or an influenza swab of the nose if the doc thinks the patient needs to be admitted. But there's no hurry on that. So that's not something you really need to get started with. If the patient looks sick with either one of these, they're retracting, their respiratory rate's high, they look lethargic,